the beginning, I would like to thank all my dear colleagues, professors from all over Egypt and outside Egypt to attend this conference with us. And also I would like to stress that this trauma symposium about the topic of non-union, you are going to have a lot of overlapping between the lectures. So in the first session, we have spoken about the basics of bone healing, what's happening inside the bone healing, and how the mechanical and biological factors from the basic point of view happens. And then for the second session, we are going to follow with the types of non-union, and as well as the diagnosis of non-union. And hopefully in the third session, we are going to have special cases of non-union. So in my presentation, I'm going to speak about how to recognize factors responsible for bone healing, whether it is mechanical and biological factors, and also we are going to discuss the appropriate strategies for treatment. So we have here this case of whatever the age of the patient, and he has this kind of fractured femur and presented to us 2 months post-debridement with this kind of bone defect. This is only 2 months. Do you think that this bone is going to heal? Can we consider this a case of non-union? Yes, we can consider this a case of non-union because we have a bone defect, although the timing is only 2 months. So the definition of non-union is not about specific timing for each bone. It is about the treating doctor believes at certain points that this fracture is not going to heal unless we have a further intervention. So what are the factors affecting healing of bone? We have the general factors, which is related to the patient himself, and also we have the local factors, which is related to the quality of bone and the quality of the fracture we have. What about the general and the extrinsic factors? The age, the nutritional status, if this patient is smoking or not, the diet and the nutrition and everything related to the patient, which needs to be corrected before treating a case of non-union. What about the local intrinsic factors? We have the type of bone, mechanical stability, biological viability, infection, and bone loss. Here in this presentation, we're going to speak about the mechanical stability and biological viability again. So we have here the algorithm of non-union. You already know this classification: the hypertrophic non-union, the atrophic non-union, the oligotrophic non-union, or the bone defect. The hypertrophic non-union, we have an excessive motion happening at the fracture site. في موشن زياده عماله بتحصل على الفراكشر سايت. البون he wants to heal بس هو البون مش قادر انه يعمل healing لان انا ما عملتلوش enough stability. So we have here a mechanical cause of non-union. What about if we have a fracture in an area where the bone ends are devascularized? احنا ما عندناش مشكله. ممكن طبعا يكون عندنا مشكله في الميكانكس. However, here we have a problem in the biology. We need to have an area where excess or enough vascularity present at the fracture site in order to make the fracture heal from this end to that end. So we can say that this is a biological cause of non-union and maybe associated with mechanical. And also we have the cases of bone defect like this, which sure this is a mechanical and biological non-union together. So we have here a new terminology. We don't have, of course, we have the hypertrophic and atrophic non-union, but in order to understand how we are going to manage the cases of aseptic non-union, we need to have this new terminology. Dr. Muhammad Abu Saud برضو in details is going to speak about this later on. So we have either a biological cause of non-union, which should be treated in a certain way, and we have the mechanical cause of non-union, which can be treated in a different way, and we can have both cases of both mechanical and biological non-union, which can be treated in a matter of a combination. So we have here, these are the risk factors for non-union. فأنا يعني عايز الشباب كده الصغنطاطين اللي معانا يقولوا لي أول حاجات اللي هي الأوبن fractures والسموكينج والage. What do you think about this? Is this a mechanical cause of non-union or a biological cause of non-union?
Mechanical cause.
Open fractures.
Vascular.
Okay. Open fractures, high energy, soft tissue disruption, smoking, poor blood supply, subcutaneous bone, tibia and ulna. So the first 4 cases are related to mechanical or biological?
Biological.
Okay, excellent. So we have a biological cause of non-union. What about the second thing, high strain or instability? What do you think? This is a mechanical cause or a biological cause?
Mechanical.
Mechanical cause, excellent. So we have another cause of non-union. What about the infection? When you have an infected bone, what do you think? We have a mechanical cause of non-union or a biological cause of non-union?
Both.
Both. Excellent. So we have both biological and mechanical cause of non-union because the infection itself may cause the implant to get loose. So we have both mechanical and biological causes of non-union. And we have, of course, the surgeon himself who can devitalize tissue and do some mixing of principles. And this is going to be a mechanical and biological causes of non-union. So let's now have a strategy in treating non-union. First, we have to exclude infection, and I'm not going to speak about this because this is going to be spoken by Dr. Baha in next presentation about the infected non-union. And then we have to correct the extrinsic factors related to the patient, the general condition of the patient, is he smoking or not, is he diabetic or not, and everything related to the extrinsic factors of non-union. And then let's decide the cause. If it is a biological cause of non-union, so we need to have a vascular bed in order to make the bone heal from this side to this side. Either we can prepare vascularized bed using a bone graft, whether it is vascularized bone graft or a non-vascularized bone graft, as well as some bone substitute, as you have listened to the excellent presentation by Dr. Ali Fergani. Or if we have a mechanical cause of non-union, we need to support this mechanics in order to allow the biology. كلام اللي قاله دكتور سيد مرسي من شوية. In order to support the biology, in order to make it heal from this side to the other side. And the mechanical causes, mechanical treatment of non-union can be done using either restoring the alignment, either doing compression plate and absolute stability, either doing ream nail, plate over nail, leg screws, and compression plating, as you are going to see in the next few slides. And if we have both causes of biological and mechanical, we can do a combination of those techniques. So let's go now with some certain examples in order to understand this. We have this patient who has fixed his bone using anatomical log distal femur plate, and he has this kind of non-union. What do you think the problem here? Is it related to mechanical or biological?
Mechanical.
You see here the plate as Dr. Mustafa Sabit described. Plate span ratio is okay, relative stability is okay, nothing related to nothing related to any metal failure, no loosening around the screws. So the problem here in this cancellous bone is related to biological causes of non-union. So if we have a biological cause of non-union, what should we do? قول لي نحب نعمل ايه؟
لو هو في مشكلة vascularization ممكن يبقى graft.
Okay, so we have done for this patient as Dr. suggests, اسمك ايه؟ As Dr. Muhammad Ali suggested, we have done bone graft for this patient, and eventually this bone has been healed. And we have here a smoker patient, diabetic patient, who has this kind of fracture shaft humerus fixed by the interlocking nail of an anti-grade method. I don't know what has happened here. So we have here a non-union again, mechanical or biological or both. What do you think?
Both.
So we have here both causes of non-union. How would you like to treat such patient?
We must remove the implant and do another mode of stability and put a bone graft.
Okay, so you are going to add a bone graft and what else?
And the change method of fixation, removing the implant and put another implant.
Okay, so he's going to remove the implant and do maybe compression plate and graft? Okay, so this is what has been done. Compression plating and graft has been done for this patient, and eventually this fracture has been united. Again, we have a fracture shaft humerus, where you see the elastic stable intramedullary nail is doing nothing. It's just intramedullary present inside the bone, creating nothing, no mechanical stability at all. So the problem here is about mechanics. So let's do compression plating, and eventually this fracture is going to heal. What about this fracture scaphoid? What do you think? When you have a case of non-union fracture scaphoid, Omar? Biological mainly, and maybe mechanical. So we have here in this problem, it is mainly biological because it is related to the blood supply of the scaphoid, and maybe mechanical. How would you like to treat this patient, Omar?
I will treat it with open reduction and graft internal fixation.
With which kind of fixation?
Screw.
Okay. So Herbert screw and leg screw and graft has been done to this scaphoid patient, and this fracture has healed. We have here a fracture neck of femur, vertical fracture fixed by 2 leg screws. and this is a vertical fracture. So here the problem is related to mechanical or biological? It is mainly mechanical here because this is a vertical fracture where we have a lag screws angulated perpendicular to the fracture side. So we have here the shearing force. How would you like to treat this mechanical problem? Osteotomy, okay, so restoring the alignment of this fracture neck of femur. So the problem here is mechanical. We have to restore the alignment and doing osteotomy, and this is the kind of healed fracture neck of femur. And we have here this kind of femoral shaft fixed by interlocking nail who has unreamed nail, and we have some excessive motion around the fracture site. So this is a mechanical problem again, where we can close this gap by putting simply plate over nail. It may be added with graft, or it may be added by compression of the fracture site over the nail until you have fixation, healing of this fracture. And here we have a retrograde nail with hypertrophic non-union. So the problem here is mechanical problem. So we have here, you see there is no distal locking, okay? So the bone is doing now toggling around the nail. So we have here a mechanical problem. How would you like to treat this mechanical problem per se? Plate over nail, yes, or reamed nail, maybe reamed nail with interlocking screws. So we have done a compression plating only for this patient with removing of the retrograde nail. Okay, so we have different methods. We have here this shaft fracture femur. This was a simple fracture. The surgeon tried to do just only the relative stability and bridge plate. So here he is mixing the principle. The fracture was simple at the beginning, and he tried to fix it using a relative stability. So the problem here is mainly mechanical problem, okay? But there is also a bone gap is present here, so it may be associated with biology. How would you like to treat this patient other than removing the implant and do what? Compression plate, yes, plate with absolute stability, either to do compression plating or leg screw perpendicular to the fracture site, and you can add also a bone graft. So this is what has been done, and this is the quality of healed bone. Again, we have a fracture shaft femur, hypertrophic non-union. So this is mechanical. How would you like to treat this patient? If you are going to do dynamization, this will create another instability. Okay? So the problem is this: there is excessive motion around the fracture site. How would you like to fix this fracture, this movement? Plate over nail. So we have a mechanical problem. Plate over nail has been done, and healing of this fracture. And here we have our last case. This was a simple case of fracture shaft humerus. It was nailed, then non-union developed, then plated again, and then non-union also developed. And then metal removal has been done, bracing of the shaft of the humerus, and grafting also has been done. Non-vascularized graft has been done, and still we have a non-union. So the problem here is biology, exactly. It's not about the mechanical. So biology, how would you like to treat this patient? Vascularized fibular graft has been done for this patient, and this is the state of the shaft of the humerus after healing of this kind of difficult shaft of the humerus fracture. And here we have an open type 3A tibial fractures where bone transport was done, and then they were waiting until the transported bone reaches the docking site, and they have fixed it using a plate. When you look closely to this plate, it's broken. So the problem here is mechanical and biological. So what they have done, and also you see that there is a problem in the proximal part of the tibia. So what they have done is that they have done corrective osteotomy proximal, reamed interlocking nail, and fixation and compression at the fracture site distally. And this what was the situation after doing all of these difficult surgeries. So the take-home message of this presentation is that you have to understand the basics of how to do it in a proper way from the start. How to improve the general condition of the patient, how to exclude infection. You're going to listen it from Dr. Muhammad Abu Saud and from Dr. Baha. mechanical, biological, or both, you need to understand, and you shouldn't depend only on the plain X-ray. You need to have a prolonged history, starting with the history of the patient, different investigations in order to help you. If you have a biological problem, so you can go with graft, bone substitute, that may be associated with mechanical problem. And if it is associated with mechanical, you can do ream nail, plate over nail, leg screws, or realign the mechanics by doing osteotomy. Thank you very much.
شكرا.